Recording in progress.
So, good evening, everybody. Hello, everybody. This is Alexander from the Virtual Global Spine Conference. I see the record has started, and I want to welcome tonight's special guest, Dr. Sudarshan Munigangaiah. He is a true expert in adult and pediatric scoliosis surgery, and I'm beyond thrilled to be able to host him because I know him since years. He finished his med school in India, and then he was trained in Ireland and did his fellowship in Alder Hey in Children's Hospital in Liverpool. And he's still working in Alder Hey Children's Hospital and also in Oswestry, famous location, famous hospital for the Oswestry Disability Index. And I'm happy to hear and to learn from him. And perhaps we have to warn because I guess the scoliosis we see tonight are extremely large. And I'm happy to be able to learn from him when he's telling us about his surgical strategy in dealing with these extremely large curves. So please, Sudarshan, I will hand over the mic to you. I'm beyond thrilled to learn from you.
Thank you, Alex. Thank you for the invite and introduction. I hope everybody can hear me. So I work in, fortunate enough to work in two university-affiliated hospitals in UK. And both Alder Hey and Robert Jones Agnes Hunt Orthopedic Hospital in Oswestry connection goes back to during the First World War. And during that time, this surgeon called Robert Jones, he was a British Army surgeon who used to work in Liverpool Children's Hospital, now called Alder Hey Children's Hospital. And he used to travel to Oswestry to work along with a nurse called Agnes Hunt. And that built the hospital in Oswestry. And he's the man in UK. He has a quite significance because of he was the first man to use Thomas splint in First World War, which saved life because of the long bone, prevented the death in more than 60% long bone fracture during the World War One. That's his contribution to orthopedic surgery, Robert Jones. So I'm fortunate enough to work in the same two hospitals. So let's begin the presentation. So my presentation will have introduction, indications, halo gravity application, method of halo gravity traction, and our recommendations. And also I'll share some experience with our unit and also the surgical technique key points. So Hippocrates used used a traction, Hippocrates ladder, which was used in treatment of scoliosis way back before Christ, and also after Christ, Oribesus added another. He's a Byzantine physician who added a bar to a Hippocrates board for treatment, which is modified later on. So it's not a new concept. It's actually quite halo gravity traction is a quite old technique, and the current version was actually first used by Dr. Nicol and Parry. They used initially halo skeletal traction for scoliosis, and first halo gravity traction was used by Dr. Stagnara, who is famous for his wake-up test in scoliosis. And Prof. Hudson popularized halo pelvic traction. And later on, halo gravity traction replaced the distal pelvic fixation to allow gravity. And this halo gravity, the beauty of halo gravity traction is that you can use it in the bed, you can use it in the wheelchair, and also you can use it while you're walking. So this is an example of a child with the halo gravity traction walking along in the ward. So this is a halo gravity traction with the wheelchair modification. So in the modern times, the preoperative halo gravity traction for very large scoliosis has been quite popularized by Professor Buachi, and his group, which is based at Focus Hospital in Ghana. And SRS Global Outreach has published on this, which then became quite established method of treating extremely large scoliosis. And I was fortunate enough to meet the man himself or during several SRS meetings and having a one-to-one conversation regarding this. So this is what we face in NHS. Sometimes we presented with very large scoliosis, almost like omega curves. You would be thinking like, how could possibly children present like this in modern day England? But sometimes we do get time to time quite a jaw drop, surprising first presentation, kids presenting with severe scoliosis like this. So severe scoliosis or rigid scoliosis more than 100 degrees. So the way I assess, I would call somebody flexible or rigid scoliosis would be normally I take them to do a traction film in the theater under general anesthesia. And a person, we will put some bed sheet under the axilla, and another assistant holds the leg and gives a traction. And the third person, the surgeon himself, puts on a lead hand and do a reducing maneuver or the convexity to straighten. If the curve reduces less than 50 degree, then in my experience, you should be able to do a surgery straight away without any halo gravity traction. If this does not reduces below 50 degrees, then this is a rigid curve, and that's when you need to put them on halo gravity traction. So this is another example of an extremely large scoliosis. And this is another girl, 13-year-old girl presenting. This is X-ray on first presentation. So what are the indications? In Liverpool, we get a lot of early onset scoliosis, and quite very early on. This is one of the curves that I've seen. I saw this child when he was only like 1.5 years old, presented with almost 100 curve. This X-ray is at almost when he was nearly 3 years of age. As you can see, he's got a well over 120-degree curve. And this is kyphoscoliosis as well. And he's an unknown syndromic kid. So this is the MRI shot where you can see such a rigid curve in such early on. So a rigid kyphoscoliosis in dystrophic curves you can use. So this is one of the NF1 kids where he's got a dystrophic angular kyphoscoliosis. And he also had a rib dislocation. Two ribs had dislocated into the spinal canal, causing myelopathy. He developed acutely he became acutely myelopathic. So this is a 3D reconstruction. As you can see on the convexity, there's his two ribs are dislocated into the spinal canal, causing, and also you can see almost subluxation of a vertebra over another, causing acute kyphoscoliotic deformity. And you can also use this in a rigid neuromuscular scoliosis as well. So under GA, so halo gravity traction, halo application happens under GA. I would infiltrate some local as well, where the pin sites go. And a prior CT scan is essential if it is associated with craniofacial abnormality, especially sometimes the kids can have the sutures like which are unfused. So you need to be aware of these, where you're applying your pins. So usually I would prefer 6 to 8 pins and 6 to 8 inch pounds, and 2 to 4 and 6 pins, like 6 to 8 pins. So rule of six, I would call it 6 to 8 pins, 6 pins, 6 inch pound, two frontal, two parietal, and two posterior pins. So a frontal pins, you need to be aware of safe zone, avoid supraorbital or supratrochlear nerve, and also you need to avoid the muscles of mastication as well, so that your pin site doesn't get infected. And lateral pins avoid as I said, avoid muscles of mastication. Posterior pins 1 centimeter above the posterior pinna, and also all the pins should be just below the equator to have the good grip on the skull. So a traction in the bed, traction in the wheelchair, and traction in the standing frame. So we have all these designed by our medical engineering, and every wheelchair has to be custom made for each child for health and safety reasons. So it cannot be reused. So each and every time a child goes through this, we need to build this for them specifically. And also, we normally start with 5 to 10 pounds, and which is a 20% of body weight, and then increase every alternate day about 1 to 2 pounds, and reach up to 50% of body weight, and every day at least 2 to 3 times my fellows go and examine the cranial nerves, because obviously the skull pins and also traction, halogravity traction itself can cause traction neuropathy, so that needs to be kept in mind. So normally at our institution we keep 4 to 6 weeks of traction in hospital. In hospital, we can't discharge them. In Ghana, Professor Buachi, and even in China, I think they send home, they send patients home on traction, but in UK we are not allowed to do that. So what we tend to do is we do a standing X-rays of whole spine with every 2 week gap, and that gives us a good estimation of what the traction is doing every 2 weeks, and depending on how much improvement is happening, I then take a decision whether to operate at 4 weeks or 6 weeks. So typically we don't give traction more than 6 weeks. So interestingly, most people think that the scoliosis, the traction helps the coronal, but it's actually what it does in the sagittal plane is also amazing, which I'll show you in soon. And regular pin site care can be troublesome because pin site can get loose, pin sites can get infected. So this is an example of that kid that I earlier showed. As you can see, this is a result after 4 weeks of traction. As you can see, there is a significant improvement in coronal pain. but not just the coronal plane, but you can also see how massive, how the lordotic thoracic spine has at least become now still in lordosis, but at least it is reaching neutrality, at least just with the halo gravity traction. So this again, this large rigid curve in this young girl, as you can see, it does significantly help not only coronal, but also you can see the difference sagittally. This is at 4 weeks X-ray. So recommendations to avoid complications. So a multidisciplinary approach is very, very important because this is one of the most laborious tasks to keep a child or adolescent in hospital with 4 weeks or 4 to 6 weeks in hospital. Putting weights, giving them pain can be quite arduous task, and it is not well tolerated by many people. So it really needs like a very team approach. Involves physiotherapist, occupational therapist, dietitian. Often these kids are malnourished, so you would have to. So while they're in the hospital, you can build them up with good nutrition. Sometimes they do have hematological abnormality, like the PT may be raised. So we have that time, like in during that time, to correct their coagulation profile with vitamin K or whatever. And also, there is often the kids to reach that level of curves. There is also a lot of social issues, like where and psychological issues. So this is the chance when these children come in, we can get them involved with a clinical psychologist, pediatrician, and social services, um, so that we treat them holistically. So pin site infection can be treated with appropriate culture and sensitivity and antibiotic treatment. CSF leak, if you leave the pin for too long, can be problem. And even if it happens, majority of the time, just simple suturing, like with helps and usually stops. And you can also put some gel foam, and also then compressive bandage, and appropriate antibiotics to be given if there is a CSF leak, so that they don't get a meningitis. And also, developing a CSF fistula is a rare complications, but we also have neurosurgery on site in case if we need them. But thank God we haven't been able to need their assistance in this matter so far. So this is a neglected scoliosis, an immigrant child. As you can see, a quite severe kyphoscoliosis. This is X-ray, AP and lateral. So we started like halo gravity traction in Alderhay in 2018. So from 2018 to 2025, we treated about 18 cases in halo gravity traction, followed by scoliosis correction instrumented fusion with Ponti's osteotomy. These are the splits with regard to the early onset scoliosis, syndromic AIS, and NF1 patients. And mean age is 11.2 years, and none of the cohort needed any VCR. So these are mean curve was actually a pre-op angle was about 100, just over 100 degrees, and it almost reduced by 50% with 6 weeks of halo gravity traction. And also, this is the kyphosis. As you can see, from mean of 75, just over 75 to 43. So there is not only coronal but also sagittal plane improvement with halogravity traction. So this is the end result of that child, where you can see there is a significant, just by doing so typically I do 4 to 5 Pontis osteotomies at the apex for these kids, and usually I use a mix of freehand and also navigation, like, navigation in typically over the apex or proximal part of the apex. I will just use a navigation in that area, and the rest of the screws go freehand, and then I'll do a Pontis osteotomy depending on 3 or 4 or 5, and other soft tissue releases. And as you can see here, a very severely lordotic thoracic spine. You can see that now the thoracic spine is kyphotic. So again, even though this result might not be optimal, but starting point for this curve was not really optimal. But the results of this is pretty reasonable for this type of rigid curve. So this, again, this rigid curve, as you can see, multiple Pontis as well as the Smith-Peterson osteotomies here resulted in reasonable coronal and sagittal plane balance. So complications, there was no neurological, we didn't experience any neurological complications. We had 2 proximal junctional failure, particularly in, these were both early onset scoliosis. So we had to extend the fixation into the neck, and we had 1 PJK in that earlier early onset scoliosis as well. The young kid that I showed with the severe 110-degree scoliosis. So initially I had a spine to rib construct for that child, but then when he had a PJK, I revised that to spine construct. And then 1 proximal anchor failure on the convex side, which was revised. And 1 patient had a fatigue failure of the metalwork and was revised to dual rod as well. In kids, most often, like, we don't use that much dual, multiple rods, but in some rigid curves, especially kyphoscoliosis, where if you're not able to instrument the apex, if there is a large gap in the instrumentation, then probably it's worthwhile using dual rod construct. So key points is that it is very time and labor intensive. I couldn't do this without the help of my excellent team at Alder, particularly our specialist nurses, because these children stay in the hospital. They get a bit of a hospitalization itis, like, they, which can be sometimes difficult, especially if families as well stay for that length of time. And halogravity traction achieves good coronal and sagittal plane correction. And most of the correction, in my experience, it happens in the first 4 weeks, as I showed that graph. And intraoperatively, what I found is that the people that I apply halogravity traction, so I don't use the traction intraoperatively. So they get the 4 to 6 weeks of halogravity traction, but then I take off the frame under GA, and then so I noticed that actually their spine is much more supple than if I'm not done the halogravity traction for a very rigid curve. And Possibly, the sample size is very small to say that less risk of neuromonitoring alert, just anecdotally, because there is a time for um, 4 to 6 weeks of gradual ligamentotaxis, theoretical, but could not be proved, but avoids the necessity for any anterior release, three-column osteotomies in most of the cases. But sometimes we have to do like three-column osteotomy for congenital cases, but most non-congenital syndromic and extremely large idiopathic curves, we should be able to avoid most of the time three-column osteotomies. So these are some references. So I really acknowledge my contributions, my colleagues, and my team at Alder Hey. So when the life throws you a curveball at you, you have to be smart. Like we do have, we time to time see very extremely large curve presenting our first presentation. So that's why it made me to think that we need to change this. The only way, especially uh, in this time, Gen Z, like social media a lot. So I thought I'll just come up with a simple idea of ABCD of scoliosis. As you can see, A is asymmetry in the back and waist, B is bend forward, C is check for curve, D is diagnosis by X-ray. So this, I came up, I worked with some charity called Scoliosis Support and Research, which we made this nice poster. Anybody can use this, and parents, dance teacher, often, like, as you people with people who treat scoliosis know that most of the time children, parents notice they're on holidays, they have something wrong with their back, or dance teachers, swimming lessons, that's typically when it gets picked up. So if you make the or physiotherapy, if they're having some back pain, the physiotherapist notice. So if you make this poster available wherever, like in gyms, swimming pool areas, public GP surgeries, physiotherapy centers, it can be quite useful in my opinion. And thank you very much to Alex for the invitation. And the reason I put up this photo is the in the background, I'm from a place called Bangalore. That's where I was born and raised. I went to medical school. So the behind what you see is the Mysore Palace of Mysore. And today is a 10th day of Navaratri. It's a Hindu festival. And this is like, today's photo where this elephant is carrying the deity, which is made up of solid 80 kg gold. It's a female goddess of our state. So every year, this procession happens with at least 10 to 12 elephants, with thousands and thousands of people gather to see this procession. So I thought something cultural today. This literally happened today, but I missed it. But I would love to bring my kids someday to show them what our culture is. We'll end the presentation at that note.
Oh, thank you very much, Sudarshan. That was really great. And these impressive curves, impressive corrections you have done. And it's always when you have to convince a kid and the parents and the family to stay in hospital, it's so much about trust. It's so much about dealing with fears. I guess you see them several minutes a day, and your team covers like 18 hours a day. It's not possible without a huge team. May I ask you, do you have a dropout percentage, like families who after 2 weeks say, "Oh no, this halotraction, this is nothing for us. We want to quit this program." Do you have any patient who's not convinced during the process?
To be honest, no, actually, none of our patients have backed up so far, which I
Yeah.
think it might be. We try to show the incentive is like we show them after 2 weeks, we take an X-ray and show them what
Yeah.
difference it made. I think that kind of motivates them a little bit.
It's convincing X-rays, eh?
Yeah.
You mentioned that it's painful. Um, Kids and pain. I remember it was always very difficult for me to judge what is pain for a kid. Do you have any special advice from your
So,
experience? How
so,
can you deal with
so
this?
yeah, we do have a very good pain team. So they do come around, they manage the acute pain. So typically at the probably first 2 to 2 weeks is not that painful. But the first day is quite painful when you apply the halo because they're not used to it. Like when they come out, like especially if you apply for a 3-year-old, 4-year-old, they're very painful for the first day. So that's why we tend not to put on the traction for the first day. We just apply the halo and leave it for one day, and then we get the pain under control, and then I think that it only start to become painful after 2 to 3 weeks of traction when the weight is increasing. So typically when you start the weights, it's not painful because by that time it's fixed in the bone, and so when you irritate the periosteum, when you apply, that's when it's painful. And then once you start the traction, it's not painful. But when the weight becomes 50% of your body weight, that's when it start to cause them some pain and discomfort, especially as the weight increases. But we tend to manage with the pain management. We have a acute pain team who come regularly, do the rounds. But amazingly, kids are so resilient and clever. What they do is eventually, during the night, no matter how much you leave, they try to migrate in the bed so that the weight rests on the ground. You know what I mean? Like, so we are also become clever, and then we make sure that it's so short that it doesn't touch the floor. We've learned the
It's
lessons.
it's a struggling with physics. And Sudarshan, may I ask you, you mentioned several have got malnutrition and you have to optimize everything. But bone metabolism in kids cannot change within 4 weeks.
All
Can
right.
you give us some impression? What kind of bone quality do you find in your patients?
So, like, it can be quite challenging because you got to work with what you have in children because it's not like a degenerative scoliosis because of their growth. Like, you can't postpone like a adolescent who was presented with like 120-degree curve. You can't sit and like wait for another 6 months for the bone density to increase. You got to work with so to be honest, most of the curve that I showed, the adolescent idiopathic, they're not the biggest problem. I think the biggest problem is the neuromuscular and early onset scoliosis. So early onset scoliosis, um, if you operate on less than 5 years of age, sometimes the bone is quite cartilaginous. When you put the screw, like the screw looks very good, like particularly the proximal, like T3 T4, the screw go in very good position. But 3 months down the line, 6 months down the line, you see there, you see halo around it, or it start to becoming loose or becomes prominent. So it can't withstand a day-to-day, like a non-fusion procedure. That because though you can't stop the kids from doing their activities and stuff like that. So it's more problematic and also most of our failure are in early onset scoliosis.
Have you got you tried to optimize bone metabolism during the process, or is it
Uh,
just
only
without?
No, only if they have endocrine problem. If only if they have endocrine problem, then we do. If they have some problem with the bone metabolism, we do. But otherwise, no.
Yeah. May I ask you, what is the expectation when you operate a kid with a extremely large scoliosis, age 11 or 12 years?
Mhm.
The final body weight height when they are 18 years, when they are grown, when they are adults, what can the kids expect? How will they look like? Because the spine won't be able to grow. Um, do they have fears? Do they have concerns about this?
To be honest, like if we if we fuse them quite early, like for example, 10 years of age, like if you do a definitive fusion at 10 years of age, what I've seen is the body, the trunk looks very short compared to their limbs, and
Mhm.
they do look slightly abnormal in terms of, but every kid is a quite different, to be honest. It's very difficult to generalize because some of the kids are very psychologically, like, have a body image, and this um, concept of how they should look and all that. But majority of the time, majority kids are very thankful, like they're very, because they know that what they have gone through, and how big was the curve, and any improvement they do appreciate, like but very few kind of stuck with, oh, my rib is still sticking out this particular way. They have very specific concern, some kids, but majority are very, very, very grateful.
Yeah, I believe that they are very grateful because the correction is dramatic, and I think it's a life-changing surgery. It's a life-changing treatment. May I ask you a personal question? Because you said to me before we started the recording that you do like 60% pediatric and 40% adult.
Correct, yeah.
The last pediatric surgery I have done was in my residency 16 years ago, and I'm pretty, pretty challenged every day by only doing adult surgery, adult spine surgery. How do you manage to switch to a completely different type of surgery? Or do you think, no, it's not as much different? There are some similarities. Can you point out, is there any similarity, or are these two types of spine surgery?
Yeah. So, to be honest, like they're to me they are very different cup of tea, like pediatrics and adults, but the skills are very transferable, like skills, and also principles, like the principles can be quite adopted from adult to children, children to adults, because that's what me, as being both pediatric and adult spine surgeon, I'm if I want to do some osteotomy, and often, like if you're just a pediatric spine surgeon, you don't open the canal, you don't do things, you don't like whereas in adult, like every day you open the canal, you do decompression, you're well versed with the canal work, canal anatomy. So there are things which are very transferable skills. So when you're doing osteotomy, you encounter some complication, or simple things like so those orthopedic comes principles can be interchangeable from adults to children, children to adults.
And the last question I wanted to ask you, I already asked you before, and you've had now some times to answer, to find the correct, your correct answer is because in Switzerland, pediatric spine surgery is we have too few, we have too little amount of spine surgeons who are doing pediatrics. We have several centers. If you have to choose between pediatric and adult, if there was, if you were forced to decide either pediatric or adult, what would you choose? What is more for you as a surgeon? What is more fulfilling part of your practice? May you answer this question?
Sure, definitely. I would choose every time pediatric spine surgery, to be honest. I think for me, the most fulfilling is I'm long enough, I've been a consultant now 10 years. So I've treated some of the kids. Like you can see that I began treatment 10 years ago. And now, like if you say, for example, if you're treating an early onset scoliosis, you might see them at 3 or 4 or 5 years of age. By now, they might be 12 or 13. So you do a growing rod, you grow their spine, you then do a definitive fusion, and then you follow them for 2 years. And then by the time you discharge, it's the most joyful moment is like when you follow through that and then you discharge after minimum 2 year follow-up. That's the most happiest fulfilling moment to me. So that's why I would choose pediatrics over adult, to be honest.
So it was clear. I think I don't know any surgeon who is in pediatric who would answer it differently. There's some magic with working with children. So, Sudarshan, thank you very much for being my guest. Thank you very much for presenting your strategy in extreme large scoliosis. I'm sure you have plenty of fans for life in your practice. And thank you very much on this special day. I didn't know this, and I hope to see you soon again. Hopefully in real person. So you're engaged in the SRS as well, and you have been in Charlotte at the annual meeting, and maybe we will find you in the scoliosis symposium with a higher probability than in the osteoporosis spine setting. But I thank you very much, Sudarshan. This was a great session.
Thank you. Thank you. Do you have any questions or?
I've asked every questions I've had. There are so plenty of more. One question was the PJK. Did you know from the hindsight, did you know why it failed, or have you been surprised by the PJK?
No, not at all surprised. All of the PJK was actually from early onset scoliosis. And particularly when you're treating a big curve and also in growing spine, the most of the growing system that we have is a distraction. So when you're distracting in sagittal plane, so obviously the proximal part of the spine will go into kyphosis. So it's automatic that because you're reducing your thoracic kyphosis, so that compensatory mechanism somewhere has to manifest, which will be a proximal to the metalwork, and hence the PJK. So any growing rod system, probably about 20-30% of them will have PJK at some stage.
Okay. So thank you very much, Sudarshan. This was great. We have recorded it and we will show it on YouTube to the immense gallery of I think more than 200 videos, and I'm very happy that you took the time late in the evening tonight. Thank you very much.
My pleasure. Once again, thank you very much for the audience, and also thank you, Alex, for invite. Thank you.